And as we're making that happen, I think we are ready to introduce our first speaker, who we're very excited to have today. That is Dr. Erik Jensen. Dr. Jensen is visiting us from his position as assistant professor at the Perelman School of Medicine at the University of Pennsylvania. He is an attending neonatologist at Children's Hospital of Philadelphia, completed his medical degree at the University of Washington School of Medicine, and his fellowship at Children's Hospital of Philadelphia. Dr. Jensen, as many of you know, is well known for his work in the phenotyping of patients with bronchopulmonary dysplasia and what has become known as the Jensen criteria, the characterization of BPD, which is used in the criteria put out by the National Institute of Child Health and Health Development, has become one of the standards that we use when discussing and defining the severity of BPD in the patient population that we take care of. Dr. Jensen is passionate about research and seeks to improve long-term respiratory health for premature infants, and particularly those with bronchopulmonary dysplasia. And we invite Dr. Jensen to the podium.
Give me 1 second, I think it is. Escape that.
Like stuck, huh?
There.
All right. Thank you so much for the opportunity to be here. It's my first time in Omaha, my first time in Nebraska. It's a beautiful city. I got to go out to a nice dinner last night and had a bit of a tour around, so you guys are lucky to live in such a beautiful place. Can you hear me okay in the back? Perfect. I do not have any financial disclosures or conflicts of interest to resolve. I will, however, say, though, that all the things that I'll show you today are a work in progress. So I'll show you things that are published, some of them several years ago, but I think the diagnosis, classification, and treatment of BPD is still very much imperfect, and so each of the things that I'll show you have room for improvement, and my hope is that by us meeting in conferences like this and other areas where we exchange ideas, that we'll start to have more discourse around how we can help take care of babies who have chronic lung disease. So I'll begin by giving sort of my general understanding of what I think BPD is, particularly for those of you who may be not directly involved with the care of these infants. I know BPD to be a chronic heterogeneous cardiopulmonary disease that develops during the first month following two things that are necessary to develop this illness. First, you have to have premature birth, and that leads to the arrest of normal lung development. Babies go on to continue to have lung development, right? They grow, they improve, they go home, but that process is abnormal. And then secondly, there needs to be injury from, and crucially, abnormal host response to harmful perinatal and postnatal exposures. We've all encountered babies that we make mistakes. They get an infection, they get on the ventilator, things like that. Some of them have a very profound abnormal response to that where they get very sick, and others, it doesn't seem to impact them. And sort of unlocking that mystery of which makes a baby go on to have a better versus a worse outcome is something that I think is crucial for us to figure out how to help better improve the outcomes for these infants. Why is it important that we talk about BPD? Well, it's the most common chronic morbidity that occurs in premature infants, and it's a strong risk factor for lifelong deficits in growth, neurodevelopment, cardiorespiratory health, quality of life, and a whole host of other abnormalities in terms of short and long-term outcomes. And because of those things, because it's very common, and because it contributes to enormous medical burden and cost, the field of neonatology and sort of adjacent subspecialists have dedicated enormous effort to try to prevent the illness. These data are a few years old, but we've enrolled now probably over 30,000 babies into randomized controlled trials that target prevention of BPD as a primary or key secondary outcome. The number now is probably somewhere in the order of 70 to 80 randomized trials. Certainly over 40 therapies have investigated, many ongoing ones listed in our registries where we log randomized trials. But despite that substantial effort, rates of BPD, as best we can tell, are either remaining stable or more worrisome or actually increasing in many regions around the world. And so as a result, centers like this in Nebraska and ours in Philadelphia and others around the country are forced to care for babies who have established lung disease. And of course we want to do that in an evidence-based way. And so when we go looking in our medical journals or in Google here, as I show you, clearly this is a joke, but the amount of data and resources that we have available to us to understand how best to care for these babies pales in comparison to the slide I showed you before this, where there's clearly been a lot of work that's been done. And so as a result, when we put together our best understanding of how to provide care for these babies, it's very much experiential, anecdotal, based on the things that we've seen work and those that haven't, but very little of it is based on actual sound evidence. As a result, our babies who have established lung disease, who remain in units like this, where it's a referral center getting patients from all over, we expose them to enormous numbers of different therapies, most, if not all of them, unproven in terms of who should get them, their safety, and their efficacy. And we treat infants with these variety of medications for prolonged periods of time without really understanding if we've chosen the appropriate medications for those individual infants. And so as Thomas Edison would say, there's a better way that we can do this, and we need to go about finding it. And I think one of the things that we need to do better in neonatology, particularly when it comes to treating infants with chronic lung disease, is learning from our colleagues that have taken care of children and adults with other forms of chronic lung illnesses. And I think that the folks who take care of and study patients with COPD have given us a very nice roadmap. When I was a medical student, we essentially divided COPD into chronic bronchitis and emphysema. We had the pink puffers and the blue bloaters. Since then, however, there's been an enormous number of studies and trials and work that's established a very detailed rubric of how to go about best treating adults with chronic obstructive pulmonary disease. And so this is just one example of a sort of a flow diagram that leads to how you might go about identifying those patients, stratifying them, and treating them. And when I look at that, I see three sort of main steps. The first thing we need to understand is which patients fall into the lower versus higher risk subgroups. Then once we've identified the higher risk group, the ones where we need to dedicate more of our attention, we need to classify phenotypes within those patients. And then using that information, we can go about the hard work of developing evidence-based phenotype-specific interventions and then studying those in randomized trials. And so for the remainder of the time that we have here, I'm going to sort of demonstrate some of the work that we've done at each one of those steps. Taking one step back, however, we'll think about when BPD was first sort of characterized, right? The first description of this illness and the coining of the term was by Bill Northway and colleagues at Stanford University in 1967, and they provided a very detailed description of the clinical features, the lung histology, as well as outcomes in these infants. But they didn't provide a definition for the illness. Over the years, a number of definitions emerged: oxygen use at 28 days, oxygen use at 36 weeks post-menstrual age. But it took nearly 35 years for us to have the first definition that actually provided some classification of disease severity. So in the year 2000, the Office of Rare Diseases at the NIH convened an expert working group, and they proposed the definition that's shown here, and they published it in the Blue Journal in 2001. And they said for infants that are remaining on supplemental oxygen for at least 28 days at 36 weeks post-menstrual age, we can classify their disease severity as mild, moderate, or severe based on the level of support and amount of oxygen they were receiving at that time point. And this definition serves sort of as the prevailing approach to quantify the severity of lung disease in babies essentially for the next 20 years. But over time, the type of instruments that we use to care for these babies, their outcomes evolved, the survival rates changed, and a number of limitations of those diagnostic criteria emerged. The first is that it doesn't account for high-flow nasal cannula use, which in the early 2000s was essentially unheard of in most hospitals, and now is quite common. In some centers is the most common way that they'll provide positive airway pressure in a non-invasive setting. The need to sort of count for 28 days of oxygen therapy is either misclassified, and they'll just say, are you on oxygen on day 28, or it's completely omitted altogether, and we just assess oxygen use at 36 weeks postmenstrual age. That creates heterogeneity in how people apply the definition. The need for oxygen therapy is infrequently assessed objectively, right? Does that baby actually need that therapy, or is it just something that we're providing? And then finally, that older criteria may not optimally stratify disease severity. And the example I give for that final point is these three babies here. So each of them will say born at 28 weeks and then shown at 36 weeks postmenstrual age. They would all be classified by the 2001 criteria as having severe BPD because they're on more than 35% oxygen. But one baby's on nasal cannula, and the baby on the far right is on the invasive ventilation. And I think if we were to counsel the parents of this baby, or maybe we were talking to a trainee, and they asked, is one of these babies likely to have a better outcome than the other? I think most of us would counsel those folks and say that the baby on the left is really likely to have a better outcome than the baby on the right. And we want to have a diagnostic criteria that help encapsulate whether or not that's actually true. And so what we sought to do was use a data-driven approach. So instead of having experts sit in a room and come up with a definition, can we actually use the data that we have to help address this problem and identify a contemporary definition for BPD that overcomes some of the limitations that I showed you and really improves our ability to predict respiratory and developmental outcomes in early childhood in these babies? So we did this work, and we published it a few years back in the Blue Journal. It's freely available, so if you just search for that, you can download it and get your own copy of the PDF. So the next set of slides will go through sort of the methods and then some of the results of that actual paper. So we had three questions that we wanted to resolve in this analysis. The first was to deal with a high-flow nasal cannula thing. So how best do we classify infants that were receiving lower versus higher flow cannula at 36 weeks postmenstrual age? The second was really addressing that figure of those three babies I showed you. Is there utility in having a separate severity level for infants receiving invasive ventilation? And then finally, we wanted to know whether or not the need to count those 28 days of oxygen therapy helps or hinders the prognostic accuracy of the definition. So the next three slides will show a series of hypothetical definitions that we developed, and each slide addresses one of those three questions. And each table will have a number of rows in it, and each row represents a different definition. And we began with sort of our first definition, which we modeled as closely as we could after the 2001 NIH consensus definition, here with a slight modification that in that one, right, we're not able to classify infants on high-flow nasal cannula, but we decided that that's really probably trying to give positive airway pressure, something analogous to CPAP. And so we grouped those children with the children who were receiving CPAP. And then we sort of iterated on that based on where we would group those kids and then using, again, the amount of oxygen that they were receiving as another sort of benchmark to classify them differently. The next set of definitions deal with that second question, whether or not there's utility in having a separate classification for infants on invasive ventilation at 36 weeks. And so these new definitions incorporate that question, one, without regard for the amount of oxygen, and then stratifying them based on the treatment with less than versus more than 30% oxygen. And then finally, the last 9 definitions, or 8 definitions, are the same as the initial ones that I showed you, but here we've removed the need to count for 28 days of oxygen therapy, and we simply assess what's going on with the baby at 36 weeks postmenstrual age. And we took each of those 18 definitions, and we asked which one best predicts a primary composite outcome of death after 36 weeks postmenstrual age or serious respiratory morbidity assessed at about 2 years of age, and then a secondary outcome of death after 36 weeks postmenstrual age or moderate to severe neurodevelopmental impairment. And we did that in just under 3,000 very preterm infants who were enrolled in the NICHD Neonatal Research Network generic database and follow-up registry. Our primary respiratory outcome, other than mortality after 36 weeks postmenstrual age, included any one of the following: tracheostomy placed any time between birth and follow-up, continued hospitalization for greater than 50 weeks postmenstrual age for respiratory reasons, the use of supplemental oxygen, respiratory support, or respiratory monitoring at 2-year follow-up, and then finally greater than or equal to 2 rehospitalizations for respiratory reasons prior to 2-month or 2-year follow-up. And this final outcome and then the continued hospitalization for greater than 50 weeks postmenstrual age represent about the upper sort of 2 standard deviations in the Neonatal Research Network in terms of the number of those things. So those are the kids who have sort of the longest length of stay because of respiratory reasons, or those that have the highest number of rehospitalizations for respiratory reasons. So of those 18 definitions that we evaluated, the one that performed best for predicting both our primary and our secondary outcome is the one shown here. It removed the need to assess for 28 days of oxygen therapy, and you only evaluated what was going on with the babies at 36 weeks postmenstrual age. And then it graded the severity into these three groups. So infants that were breathing in room air at 36 weeks postmenstrual age, we said didn't have BPD. Those that were receiving low-flow nasal cannula had grade 1 BPD. Those that were receiving some form of non-invasive positive airway pressure, high-flow nasal cannula, CPAP, NIPPV, BiPAP, whatever it is that you're using in your unit, we consider those kids to have grade 2 BPD. And then infants that had an endotracheal tube in place and were receiving invasive ventilation, they had grade 3 BPD. And this definition correctly classified the presence or absence of late death or serious respiratory morbidity at 2 years of age in 81% of study infants. So it's not perfect by any means, but using one data point at one time in this child's NICU hospitalization, we were able to classify correctly the outcome at 2 years of age in over 80% of the study infants. So it's not bad. The next set of slides will go through some of the epidemiology of the outcomes in the derivation cohort for applying that definition. And so I show you here the rates of the primary composite outcome for respiratory illness and, again, for neurodevelopmental impairment. And you can see for both of them, there's this nice stepwise increase as you go from one grade of BPD to the next. The other thing you'll note is that infants without BPD are not immune from having a poor outcome, right? The rates are the lowest in that group, but children who we don't classify as having BPD, we know some of them will go on to have poor respiratory outcomes, and some of them will go on to have poor neurologic outcomes. But when you contrast that to the babies who have grade 3 BPD, where nearly 80% of them are having severe respiratory illness and severe neurodevelopmental impairment, again, I think we're identifying why those really represent a unique cohort of very high-risk infants. Breaking out the individual components of our primary outcome, again, we see for each of these that stepwise increase in the frequency of things that we'd like to avoid. Tracheostomy, long hospitalizations, rehospitalizations, need for home respiratory care. And for each of these, except for one, you see that there's about a 3 to 5-fold increase as you go from grade 2 to grade 3 BPD. Again, sort of hammering home the point that those are really a unique subset of infants. Other measures of healthcare utilization that weren't included in the primary outcome, again, show that same thing, a very intimate relationship with the healthcare system for these children after they go home, feeding difficulties, inhaled medications, reflux medications, having to come back and see our pulmonary colleagues, so on and so forth. So I think if we're trying to convince folks that they should adopt a new diagnostic test or a new definition for an illness, we need to do both internal validation and external validation. And so I'll show you here some of our internal validation work where we compared the prognostic accuracy of the definition that we've proposed through a data-driven approach versus the 2001 NIH definition, which has sort of been the prevailing one up until then. And so when we look at the C statistic, which is the area under the ROC curve, or essentially a single measure of diagnostic performance, we see that for both our primary respiratory and our primary neurologic outcome, that there is a modest but a statistically significant improvement in the prediction of both of these endpoints. So as is sometimes the case, people sort of scoop you a bit. And so when we were in the process of doing this work, the NICHD convened another expert workshop, and they had a bunch of folks sit in a room and come up with what they thought was the new best definition. And this is what they proposed in the publications listed here. And I won't go through each of the permutations for you, but I will highlight one thing, that the highest grade severity babies is somewhat analogous to what we've proposed in that there's a subset of infants who are included receiving invasive ventilation, but it also adds with that a whole host of children who are receiving other forms of non-invasive support. And one of the things that we identified, as I've showed you in all of those sort of bar graphs, right, is that those infants on invasive ventilation may well be a very unique group. And I think this slide helps point that out as well. This is each of the 18 definitions that we looked at, and they're rank ordered in terms of their prognostic performance for our primary and secondary outcome. And you can clearly see that the best definitions, all the top 12, are the ones that classified those group of infants as a unique sort of separate cohort of babies. And so when we compared the prognostic performance of our definition to that 2018 one, again, we see, similar to the 2001 definition, that there's a modest but statistically significant improvement. And much of that, I think, is driven by the fact that we've isolated that high-risk group of babies. What about external validation? Well, studies are beginning to emerge that are looking at the prognostic performance of what we've done. And here's one that we did using the Vermont-Oxford data. Almost 25,000 babies born less than 30 weeks in the year 2018. And again, for things that we'd like to prevent, these are in-hospital outcomes, sort of discharge outcomes, but we see that same trend where there's increasing rates of morbidity and mortality and prolonged length of stay for infants with higher grade BPD. A few studies that I was not involved with, that I couldn't have influenced the outcomes of. Here's one from Orange County, a single center study where they looked at infants and evaluated the cost of their hospitalization through the first year of age. And these box plots here show the sort of median and the range for the cost using three different definitions: the 2018 Canadian Neonatal Network definition, the 2018 NICHD definition, which I showed you before, and then the one that we proposed using NRN data. And you can see that as you go from not having BPD to some degree of BPD, each of these propose that there's going to be a stepwise increase in cost. But the one that we've identified is the only one that really has that consistent gradation where there's an increase in cost as the severity of BPD increases. And we see that same phenomenon in other studies that have looked at neurologic outcomes. So this is a single-center study from a large academic hospital in Seoul, Korea, where they looked at 2-year neurodevelopmental rates and found, again, that same sort of stepwise increase is preserved when we look at the definition that we propose through a data-driven approach, but really it's not when you look at other definitions that lump together less sick and more sick infants at the higher severity range. So we'll pause there and sort of say, how have we done so far in that sort of the 3-step process that I suggested might be a way that we can go about better treating these babies. And I think for the first step, I give us an A-, B+, right? I think we did our diligence in trying to go about a data-driven process, but ultimately we're still diagnosing BPD based on a therapy, and we don't have an objective diagnostic test, some imaging, some biomarker, something like that. I do think that that's like the next frontier, but it's not something that's available to us yet. And so I don't think we can really give ourselves an A until we're at the point where we have a robust and objective test that we can apply to these babies. But I think we've made progress. So what about phenotypes? Well, we've proposed that the kids with more severe forms of BPD can be classified as having the presence or absence of one of these 3 areas of disease: severe parenchymal lung disease, cardiac issues related to pulmonary hypertension, and then large airway issues related to tracheal bronchomalacia type findings. And so we did a study at our own center where we looked to quantify the presence and frequency of each of these 3 characteristics. We did it in 76 very preterm infants that received care at our center between 2011 and 2015. We used the OCI criteria to grade the severity of their lung disease on CAT scan, and the criteria are shown here. They basically break up the evaluation of the CAT scan into the presence or absence and severity of hyperexpansion, emphysema, fibrous interstitial disease, and then an overall impression, with the scores being able to range from 0 up to 18. And the OCI group suggested that a score of 8 or higher is indicative of severe parenchymal disease. We looked at all of the echoes that these babies had, and we reanalyzed them looking for presence or absence of pulmonary hypertension, defined based on the criteria here. Essentially, if you have a tricuspid regurgitant jet, we use that flow as a way to diagnose PH, and if you don't, then we look at bidirectional shunts and flattening or not of the intraventricular septum. And then we looked at the bronchoscopies, the tracheoscopies that these babies had done. We're a fairly diagnostic-heavy group, and if we didn't have results of that, we used results from dynamic airway CT to help classify whether or not these children had large airway malacia. We did 76 babies. In 73 of them, 96%, so almost all of them, we could classify those children as having at least one of these disease components. But there were 3 babies who still met the diagnostic criteria for having severe BPD and whom we couldn't identify the presence of any one of these 3 components. Parenchymal lung disease was the most common, 75%, pulmonary hypertension next, and then large airway disease. But you'll see even there, in this group of sort of referral, fairly sick population, there was a high proportion of each of these components. The most important slide, I think, from this study is this one here. And this Venn diagram shows the proportion of those 73 babies that fit into each one of these potential buckets, right? There's the bucket of I have only one component, I have two components, and I have three components. And in that reasonably small sample size, we were able to identify with fairly substantial numbers proportions of babies that could fall into each one of those things, right? There was those who just had lung disease, those who had a combination of lung disease and pulmonary hypertension, and so on and so forth. But the most common phenotype, or the most common presentation, was the presence of all three of these, about a third of the group. And we've seen other centers replicate this work, and that number, that 33% number, is remarkably stable across studies. We didn't have the same two-year outcome type data that we used in the prior derivation study for the definition. I wish we did, but we did look at the in-hospital morbidities that these babies had. So did they survive to discharge? Did they go home on pulmonary vasodilator therapies? Did they go home with the tracheostomy? And then we looked at it as a count, right? If you have one of those components, if you have two of the components, if you have three of the components, what is the probability or what proportion of those babies go on to have each one of these outcomes? And you can see, similar to many of the other bar graphs that I had, right, the more you sort of tack on things that are challenges for these babies, you add on lung disease, then you add on heart disease, then you add on large airway disease, their likelihood of having these things that we would hope to prevent increases substantially. So how have we done to classify subgroups of babies or phenotypes? Well, here I think we're sort of just barely getting by, right? We're not failing. I think we've begun to make some progress, but there's a number of limitations to what we've done, right? We've got smaller cohorts of kids. We don't have longer-term follow-up yet, and we are putting them into buckets that we've said are the buckets, right? We did that derivation project for the BPD definition, saying we were going to be sort of we're going to take a hands-off approach and just say, what does the data demonstrate? And so I think that's the next step, right? It's doing this in a prospective way. It's having more robust diagnostics, different diagnostics, looking for other types of characterizations of these babies, and then doing it in a way that really is driven by the data and not by the phenotypes that we believe we should be able to put babies in. But I think we're making some progress. And you can see that even if you don't quite agree with this sort of phenotype classification system that we've had, you can imagine how if we have that as sort of our framework in the middle, we can then begin to think about how we would have predisposing and exacerbating factors that may lead into children having those conditions. And then on the sort of the back end, we have a whole host of available therapies and then hopefully new therapies that will be emerging that we could begin to study within individual subgroups based on our assessment of their phenotype and then their endotype, or the sort of underlying pathophysiology. And so for the remaining little bit of time that I have left, I'd like to go through just one of these. But I'll focus on some of the work that we've done around reflux and aspiration. Each of the sort of potential predisposing factors in each of the therapies could have its own talk, and certainly all deserve their own investigation, but we've done some work here, and so I'll share that with you. And I've singled out reflux as one area where I think it's important that we do research, in part because it is incredibly common, or at least we think it's incredibly common in babies who have severe chronic lung disease. It's diagnosed at about almost 2.5-fold higher rates in children with BPD than without BPD, and about 40% of babies that have BPD are diagnosed as having reflux disease. The only thing in BPD that compares to that frequency is pulmonary hypertension. And we spend a lot of time thinking about pulmonary hypertension, right? We get echoes, we put these kids on nitric and sildenafil and all these other medications. And reflux disease is really sort of analogous in terms of the number of children we think have that problem. The other reason why I like studying reflux is because it's kind of annoying, right? There's that clinician you have that says, oh, that kid has reflux. I know they have reflux. That's their problem, and I've sort of figured it all out. And then there's that other clinician that's also in your group that says, nobody has reflux, or they all have it, but it's all physiologic. Don't treat it. You can't treat it. And then there's the rest of us in the middle that's going, I don't know. Like, maybe yes, maybe no. And I've been drawn to sort of questions like that, right? The sort of nagging things that people feel very dogmatic about without having really the evidence to back up their statements. And when we look at the way that we handle reflux, I think that confusion that we have about whether or not it's important is present in the data in terms of how different centers go about treating it. These are data from a few years ago when the BPD collaborative was quite small. But at the small number of centers, you can see already that one center here, A, right, they don't think that reflux is a problem for their babies. And center G either thinks that it's there for all of them or that they should all get a fund application for whatever reason. And then there's the other, maybe more rational centers that are in the middle that think, yeah, I think it's affecting some kids, but not all kids. But slides like this, where we see this dramatic variation, just tell me that we have no idea what we're doing. Each of these centers probably thinks they know what they're doing, but when we look across the board, I think it's fairly clear that we haven't sorted it out yet. And one of the challenges with reflux is that it is common, right? All babies have some degree of reflux. These are some data showing the percent of infants with spilling or spitting. So they're sort of refluxing up, or they're having some regurgitation. This one here says it's about 40%. There's another study from Asia that suggests about 80% of babies have it at some point. I think it would be hard to find one child who hasn't sort of vomited or regurgitated at least once in their life, and somebody said, oh, that kid had a reflux episode. It peaks probably around 4 to 6 months of age, maybe later in kids who have chronic lung disease. And then it has this really slow tail where eventually it goes away. And then when you get older and you start eating spicy food and lots of garlic and stuff, then it sort of peaks back up again. Another challenge, though, is that we know that it's really common in children. We know that it can be physiologic, but we don't have great data to demonstrate whether or not it's actually potentially pathologic in BPD. So this is one study that used pH-only esophageal monitoring and essentially said the rates of abnormal diagnostic tests were about the same in infants without BPD and those who had more mild, moderate, or severe BPD. But I've been drawn to this one study that came out of a group from New Jersey, not far from where I live, where they looked at tracheal pepsin levels in the first month of life in ventilator-dependent babies and then went on to evaluate the severity of BPD that they developed down the road. Tracheal pepsin is not perfect. It's potentially, at least one of its isomers is made by lung cells itself, and so it may not be a true indication of reflux and aspiration. But the thing that I find intriguing about this work is when we look at the kids who have severe BPD and we measure the amount of tracheal pepsin that they have, there's this huge variability from very low levels that are essentially consistent with the median range in those without BPD to those that have these very astronomical levels. And when I take that graph and I sort of put it on its side, I think this tells the story of how I feel about these babies in the unit, right? There's many children for whom it's probably not a problem. They have this physiologic reflux and it's okay. There's probably some kids where it's a small problem, and maybe it does impact them a little bit, but maybe not enough to go to the operating room. And then there's some kids who are way out there, right? And reflux might be really their driving reason why they're continuing to need oxygen, CPAP, or be on a ventilator. And that mystery is one of the things that we've tried to unlock. And taking a kid to the operating room is a pretty substantial treatment, and so we've sort of taken one step back and say, can we help sort this out by using transpyloric feeding, right? So we can do these diagnostics, but really what we want to know is if we make your reflux go away, do you get better? And so transpyloric feeding is where we take a nasal or oral feeding tube, right, and we advance it past out of the stomach, and you just kind of push it a little further, and then it ends up in the small bowel. And the idea here is that we decrease the volume of milk and fluid within the stomach, and as a result, we're going to have less material that can be refluxed up into the esophagus and to irritate the airway. There's an older study that suggests that about 13% of babies in the CHNC receive this therapy at 44 weeks. Some centers are doing it almost in all their babies, and I think the average is working out to be somewhere around 30 to 40% of kids with severe BPD are at least exposed to this intervention for some period of time. And there is sort of supporting data to suggest it might work. This is a meta-analysis that comes from adult ICU patients in whom they put them into transpyloric feeding versus gastric feeding and found that there was a significant reduction in the incidence of aspiration pneumonia in patients randomized to receive transpyloric feeds. But the infant data are a little bit more conflicting. So there was a couple of trials done in the 1970s and early 1980s that essentially took newborn vulnerable babies and immediately began them on transpyloric, or soon after birth began them on transpyloric versus gastric feeding. And in those trials, many of them were small, many of them had methodological flaws. They found that there was the possibility of an increased risk of mortality in patients that were receiving transpyloric feeding, such that the data favored the use of gastric feeding, and again that there was an increased incidence in GI disturbances that necessitated stopping feeding, again favoring the use of gastric feeds. More recent observational data, however, suggests perhaps the opposite. So this is a study that comes out of the Duke UNC group where they had babies that were initially receiving gastric feeds. They had worries that reflux might be contributing to apnea. They then converted those babies to transpyloric feeding and found that apnea and bradycardic events decreased within a few days in those children after doing so. A study that came out of the Stanford group just a few years ago looked at infants that had received predominantly transpyloric feedings versus predominantly gastric feedings and found that the incidence or the risk of death or BPD was lower in the transpyloric feeding babies and that the duration of mechanical ventilation was shorter in the transpyloric fed babies. However, though, the data from the BPD collaborative sort of suggests the opposite. There's likely to be a whole bunch of reasons why these data are confounded, but they found that infants who received transpyloric feedings had higher rates of tracheostomy and death, longer lengths of stay, and need for gastrostomy too. So it's unclear, right? We've got some trial data from babies suggesting bad things, some observational data suggesting potential benefit, and then some newer data, again, sort of re-questioning whether or not it's a safe and reasonable way to feed these babies. So we wanted to begin to sort of answer that question as best we could, but harnessing that idea that these babies are each individuals and that the way that they interact with their feeding and the way that reflux may contribute to their illness may well be different and heterogeneous. And so we conducted a series of N of 1 trials. An N of 1 trial is essentially identical to a multiple crossover trial where you have somebody go back and forth between different therapies. But the key distinction here is that the only thing that really matters in the analysis is how that particular baby did on the one feeding route or the one therapy versus the other. So you can summarize all the data, and I'll do that and I'll show you. But you do a trial like this because you believe there's heterogeneity of treatment effects, and you want to identify in each individual patient whether or not they respond well to a therapy or not. The caveat, though, however, is that in order to do that, you need to measure real-time endpoints. And so if your goal was to see, does gastric versus transpyloric feeding help babies improve their 2-year outcomes, right, this design wouldn't work. And so you need to have an outcome that you're measuring while you're giving that therapy. And for this, we used measures of intermittent hypoxemia and the amount of oxygen that babies were receiving. And we took infants who were tube-fed. They had severe BPD on some sort of positive airway pressure, and they got 2 different routes of gastric feeding versus transpyloric feeding, each of them for 4-day periods. And then they just got randomized as to which order they did them in. We did it in 15 babies. This was sort of a fellowship project that I worked on, and the characteristics of the babies are shown here. They were small at birth. They were sort of that bigger referral population by the time we studied them at 47 weeks on average, and then a range of children in terms of being on high-flow nasal cannula, CPAP, or being on a ventilator. And I'll cheat a little bit, and I'll show you the result for the summary statistic first, in part because this was completely opposite of what our hypothesis was. And I think why we use this clinically, right? Like, we don't transpylorically feed babies in hopes that they have more desaturations. We do it hoping that it's going to improve their cardiorespiratory stability. And at least in these 15 babies, we found that on average, while they were receiving transpyloric feeding, they had higher rates of intermittent hypoxemia than when they were receiving gastric feeds, again, sort of favoring the use of gastric feeding in those babies. And here now I show you the individual results for each of those 15 babies. And the ones that are color-coded in black are sort of the non-significant results. The ones that are color-coded in red are the 5 babies who had a clear and statistically significant increase in the incidence of intermittent hypoxemia. And the ones that I've highlighted in green are clearly not significant. But you might imagine that if you were to feed those babies with transpyloric feedings for prolonged periods of time, that amount of a small reduction in intermittent hypoxemia might eventually add up to where they could have a benefit. No clear signal, right? But clearly we're seeing that there's some children that are at one end of the spectrum and others that might be able to fall at the other. And so now we've been left perplexed, right? We were hoping that that sort of transpyloric feeding N of 1 trial was going to sort it all out for us, and really we found that we're not identifying the children with the kind of benefit that we hoped. And so we've tried to become more and more sophisticated in how we sort out this question. And so these are some data that we're going to present at PAS, and I'm happy to share them with you, but very much, as I alluded to at the beginning, still a work in progress. So for this, we went to what is, I think, generally accepted as the gold standard for diagnosing reflux. It's not perfect, and it certainly isn't a measure of aspiration, but pH impedance testing is where we put an esophageal catheter in, we leave it in for a day, and then it measures the presence and absence of reflux, the height of the reflux, the acidity of reflux, and then the amount of time that the esophagus is exposed to reflux. We did this as an observational study in 41 babies. So they were receiving gastric or transpyloric feeding based on their clinical prescription. This wasn't a randomized trial. And the characteristics of the babies are shown here, fairly similar between those that were receiving gastric and post-pyloric feeding. And then you can see the types of respiratory support they were on, and that's probably where the biggest sort of difference comes. There was more children on lower support in the gastric group than in the post-pyloric group. And this here is the 41 babies representing the number of impedance episodes by the height of the bar. The two different colors indicate the proportion of reflux episodes that were acidic versus non-acidic, and then the green sort of dots floating above indicate the proportion of events that reach the proximal sensor, the one at the top of the esophagus. And all I want you to take home from this is that it's hugely variable, right? We went from essentially having no reflux. Nobody had zero, but a couple of babies had like one or two, all the way up to nearly 200 reflux episodes within a 24-hour period. But when we summarized the data, we found that I think our hunches about whether or not transpyloric feedings reduces reflux may well be true. The infants that were receiving gastric versus post-pyloric feeding had more reflux, right? So post-pyloric feeding appeared to reduce the number of reflux episodes. The amount of time the proximal sensor was exposed was also lower in the post-pyloric feeding, and then the amount of time, again, lower. But what we found that shocked us was that the proportion of acidic reflux episodes in the transpyloric feeding babies was very, very high. And we got to the point while we were doing this study that I didn't even need to know what feeding route the baby had. I could just look at the impedance report, and if it had 80, 90, 100% acid events, I knew that baby was receiving post-pyloric feeding. I didn't have to look at the chart or the x-ray. So what this tells us, even though it's not a randomized trial, is it suggests that if we feed you post-pylorically, we may well reduce the amount of reflux that you have, but if you have reflux, it is very, very likely that it is going to be acidic in nature. And these are results from the pH probe analysis. So when you do these studies, you get one set of data that give you the impedance stuff, and then you get another set of pH-only analyses as well. And I think these are fairly analogous. The data don't quite reach statistical significance, but each of the observed values, the reflux index, the total reflux time, total number of events when you're just looking at a pH sensor, suggests that post-pyloric feeding has more acid reflux than gastric feeding. We're still, as I alluded to earlier, kind of digging through the data. We've got a number of other clinical measures that were recorded during it. We've looked at rates of hypoxemia and others. And so I won't get into all that, but while I was doing this study and analyzing the data, this was an interesting paper that came out of the Pediatrics with an X group, where they looked at babies that were being fed gastrically and then transitioned over to being fed post-pylorically, and their data suggested that there may well be heterogeneity of treatment effects based on if a baby was intubated versus non-intubated when they made that transition, suggesting that the infants who were intubated didn't really have a robust benefit, but those who were not intubated did. And this actually went contrary to what I had thought. Figure our kids who are at 40 weeks, 45 weeks, 50 weeks on a ventilator, many of them are hyperinflated. We're pushing down on their stomach. It's probably making them reflux a lot more. If we can just get you onto CPAP, maybe that problem will go away. These data argue against that. And so we actually kind of do our data. So I stratified the babies based on those that were on invasive ventilation when we did the pH probe and those that were not. Some of them were in room air, some of them were on CPAP or high flow nasal cannula. And again, we see that the babies that are on non-invasive support, similar to that prior study, had a higher, a statistically significant increase in the total number of reflux episodes by impedance. And it didn't really matter how we broke it down in terms of were you getting bolus gastric feeds, continuous gastric feeds, or post-pyloric feeding. If you were on non-invasive support or breathing in room air, the observed values as you compared babies on analogous rates of feeding or routes of feeding were consistently higher in those that didn't have a breathing tube in place. Again, contrary to what I had expected, but I think that we we often clinically take a baby that's on the ventilator and say, all right, that's the sick kid, right? That's the one who needs to be post-pylorically fed, who clearly has a lot of reflux that's going on and it's bad for them. And maybe it's the opposite. Maybe once we get that kid extubated and now we're pumping all this air into their stomach with a CPAP device, maybe that's when reflux might rear its ugly head. So I avoided giving us a grade here because I think it's probably an F, but I think if we sort of look at this as a glass half full, I think there's great opportunities for us to study these babies in an individualized way to really come up with what are the best approaches to treat them. And so I'll just put in a plug for one study that we got a nice score on at the beginning of the week, where we're going to do a randomized controlled trial where we do pre-enrollment pH impedance testing. We then stratify enrollment or randomization based on the presence of more mild or moderate reflux to more severe reflux. And we'll look at a number of other things that may help us identify predictors of response so that we can then sort of take that data and move to the next level of redoing perhaps that N of 1 trial with a much more robust understanding of what are the reasons why children have reflux and what are the characteristics that we can use to help identify kids who may benefit from this feeding route. And I highlight it as a multi-center one because the only way that we're going to be able to do these sort of phenotype-driven studies is if we work together, right? None of our centers have enough of each one unique baby that we can do robust randomized trials. And so we have to work together. And so this is already going to be a couple-center trial, and we're still looking for other folks who would like to participate. And certainly if this is a center that might be interested, we'd be happy to work with you. But mostly underlining multi-center here just to plug that we're going to need to be collaborative when it comes to sorting out these questions because these babies are very unique, and we don't have enough of them at any one center to answer these important questions. So in summary, I would say that there are limited robust data to establish best practices for the treatment of BPD, and that's a huge knowledge gap. I think that the new evidence-based diagnostic criteria for BPD that we proposed allow for improved classification of disease severity and represent an important step forward, but we still have work to go when it comes to best approaches to diagnosing and classifying BPD. I think objective diagnostic approaches to understand BPD phenotype and endotype, the underlying pathophysiology, are urgently needed so that we can appropriately administer therapies to babies based on the reason why they continue to be sick. And my hope, and I think this is true, that once we sort of unlock some of those mysteries and we're able to really deliver individualized therapies based on the pathophysiology, that we're going to begin to see better outcomes or continue to see hopefully improved outcomes in these babies. And so with that, I'll say thank you very much for your time. I'm happy to take any questions.
I have a question from our virtual audience asking, isn't all reflux acidic in these babies, or it seems like when we looked on the slide, there's the severity of the acidity, but the question was, is it all reflux acidic?
Yeah, great question. So the stomach makes a lot of acid, for sure, but unlike in perhaps older children and adults where our stomachs spend a large portion of the day empty, most babies that we take care of, we feed regularly, right? So they're getting feeds every 3 hours. Maybe those feeds are run over 2 hours. Maybe they're getting continuous feeds. And even when we feed them in a bolus fashion, the amount of food that remains in the stomach still can be pretty high. And we know that because, I don't know if you do that at your center, but at all the places I've trained, right, you get the gastric residual, and it's like, I got 30 mLs back. What do you want me to do with it? And I'm always like, well, if I eat a sandwich and you took my sandwich away from me, I'd want my sandwich back, right? So we know that the stomachs in these babies remain filled with fluid, and it's milk, it's formula, and that is diluting the acid within their stomach. And so I think that a proportion of reflux that babies who are gastrically fed is acidic, but a larger proportion. It's probably somewhere around the order of like a third is acidic and 2/3 are not, although it's going to be very heterogeneous between babies. But I think our data would suggest that when you empty the stomach, but you continue to feed a baby, and all of the hormonal feedback loops, cholecystokinin, and all the things that the small bowel says to the stomach to say, hey, you're being fed, let's keep making acid, let's keep preparing for more food, that's intact. And so the stomach is there, empty of milk, making a bunch of acid, and so if it's got any liquid in it and you're a baby who's going to reflux, it's just going to be acid. So we dilute the acid, but not all reflux is acid, regardless of the feeding route.
I have a question to that regarding PPI. We put a lot of our kids that, we're concerned with on PPI, and when you're talking about acid and especially like transpyloric feeds, what do you think the role of PPI for that is to decrease the acid level when you're feeding post-pyloric?
Yeah, it's a great question. And I'm sort of two minds about it. We get sort of beat into us again that you shouldn't give acid blockers because they increase risk of NEC, they increase risk of infection, they increase risk of mortality. I don't know that we've observed that necessarily in good trial data, but certainly big observational studies suggest that that's true. And they've done their best to try to adjust for illness severity, but it's hard to really disentangle this is a sick kid who I put on a PPI versus a healthy kid who I have no concerns about, so I would never put them on that medication. But you do have sort of a phenomenon here, right, where you've given one therapy that creates a problem, and then we're giving another therapy to treat it, which has its own problems, right? It's sort of, I remember like when I was doing adult ICU medicine, it's like, well, we gave them this, and that had a complication, so then we give them that, and then that had a complication, so we give them that to treat that, and it's like...
The more you do, the more you do.
Yeah, we just have never done anything.
Yeah.
But I can imagine a baby where if you feed them post-pylorically and their reflux goes from 200 episodes to 10 episodes, 15 episodes, something like that, maybe that really helps that kid. And if those remaining 10 episodes were severely acidic and it was causing still some degree of disease, might then treating them with acid blockade help? Yeah, I can sort out that thought experiment in my mind. But I do worry about us just sort of adding on therapies to treat the complications of our other therapies and how that could just spiral out of control. It's sort of like, well, I gave diuretics, and then I had to give electrolytes, and then they vomited, and it's like, did the diuretics help?
I have another question from our virtual audience. Why do we look at BPD at 36 weeks instead of full term, which is 40 weeks?
Good question. A couple of reasons. One, in 1988, I think, Andrew Shannon and colleagues at the University of Toronto published a single-center cohort study where they looked at 1 to 2 year outcomes, mostly respiratory, a little bit neurodevelopment, and they were essentially asking the question of, does diagnosing BPD as oxygen use at 28 days of age, which in the 70s and 80s was the prevailing approach, versus some other postmenstrual age marker, improve prognostic accuracy? And there they had these children who were surviving much, much longer, right? This was really the beginning of neonatology and when it was starting to become more sophisticated. We didn't have surfactant yet, but we were treating more babies, more kids were surviving, and more younger babies were surviving. And what they found is that 28 days was really too early, unless you were a 32-weeker. But if you were born at 24 weeks, and you're only a month old, that kid's now a 25-weeker. We don't expect their lungs to be better, right? So we should maybe assess it later. And so they looked at anywhere from, I think, 32 to 44, 42 weeks, something like that. And they found that 36 weeks was the time point that sort of balanced the competing effects of predictive accuracy, right? So sensitivity and specificity are kind of at a battle with each other oftentimes, where we can have improvements in specificity but degradations in sensitivity as we move the needle on which babies we're going to include or exclude it. And they found that 36 weeks was sort of the best balance of those things and maximized the area under the curve. Certainly now there's been questions about should we move it to a later time point, and I think those are important questions to answer. It's not something that we could do in the data that I showed you because we didn't have longitudinal respiratory support data at various postmenstrual ages. But a couple of studies have looked at a more dichotomous outcome of BPD. There's the Shannon group, there's the Canadian group, and then a secondary analysis of the TIP trial. And they all had different results as to which one worked best. But they were consistent in sort of one sort of combined fashion, and that was that as you moved the diagnosis of BPD later, you had an improvement in specificity, meaning that you could be more confident that a baby on oxygen was going to have a bad outcome. But as you moved it later, you had a decrease in sensitivity, which meant that you were less confident that a baby without BPD was going to go home and have a good outcome. And the consequence of that, I think, is that we often have this complaint about the diagnostic criteria for BPD, that there are children who we say don't have BPD, but go on to have a poor outcome. We said, oh, you don't have BPD, you're going to be fine, and then they end up with asthma. So the diagnosis of BPD failed us. And I don't know that that's quite true, but if that's the thing that we're worried about, moving the diagnosis of BPD later, 40 weeks or whatever, makes that problem worse. More children will be free of BPD and go on to have a poor respiratory outcome at 1, 2, or 3 years. And so if we're trying to fix that issue, which is often held up as the reason why we need to change the timing, it's the wrong way to fix it. You need to actually diagnose it earlier. If the goal is to say, I don't want to miss any babies, we already have that test. It's gestational age. Any baby who's born tiny has abnormal lungs. And if you want to follow all of them or catch all of them, you just need to follow all preterm babies. The final consequence, and then I'll move off of this, is that as we move it later and later, more children will go home earlier, and we won't be able to classify those kids. And so we've seen this consistently, that as you try to look later and later and later, the denominator keeps getting smaller and smaller and smaller because the number of kids in the hospital goes down. This is particularly problematic for non-American centers where they have regionalization of care. So the baby goes into the perinatal center, the big high-risk unit, and then they get sent back closer to home. So Canada, Australia, right, these big countries that are very geographically dispersed, they all get moved into one center when they're tiny, and then once they get on CPAP at 32 weeks and they're looking good, then they go back to their closer home hospital where the data collection infrastructure is not as robust. You'd think in this area, right, we'd be able to collect all that data, and we probably should be able to, but, you know, IRBs and legal things and whatnot, it's just we're not quite there yet.
Dr. Rose from our pulmonary department has a question. Go ahead, Dr. Rose. You can unmute yourself.
Sure. Hi, Dr. Jensen. Thanks for the presentation. I had a question because one of my interests is always in, you know, tracheostomy timing and decision making for that, which is its own challenge. But from the BPD classification paper you all published in 2019, I've always been interested in the conditional probability of one of those groups. In the grade 2 kiddos, it talks about that there were about 15% or 90 that were in the hospital for respiratory issues at 50 weeks. And then there are 28 or 5% that went on to tracheostomy. I've always wondered, is that 28? My assumption would be, it may not be true, is that all made up of the 90? Because in that case, in those kids, the conditional probability would be closer to almost a third. I was curious if you can verify that, or if that's not true.
You know, I'm not going to be able to verify it right now because I don't have it right in front of me. But the proportion of babies and the numerator denominator of infants that have each of the outcomes are reported in the paper, and so. If you look at the BPD severity grade, that'll be at the top of the table representing each of the columns, and then you go down to the rate of tracheostomy. That will be the number of babies who had each of that severity grade who got a trach. And so if the numbers that you're quoting are pulled from that, then that's accurate. We didn't sort of lump the trach kids with the more severe group or whatever. So each of the outcomes are reported stratified with a numerator and denominator rate. So if that's where the numbers are from, that's true. It's certainly also true in our experience that some children who are on CPAP for prolonged periods of time end up getting a trach. They do at our center. It's not a huge number, but it happens. And we see not infrequently the phenomenon at our place where a kid has been sort of tucked in a corner and they're on CPAP or they're on like high flow of 8 or 10. And then the kid's not really getting any better. They're not really growing. Someone decides, let's get a blood gas. And the kid's CO2 is like 90 or 100. And then they're like, we should get an echo. And they get an echo, and it's like the septum's bowing, and right, their estimated PVR is through the roof. And they're like, we should send that kid to Nebraska Children's or to CHOP or whatever. And you get the kid, and you're like, this is not going well, right? And then you intubate them, and then like it's still not going well, and they end up being a really sick kid, and they need a lot of work to get them better. And some of those kids will go on to get a trach. It's less common, but we've also trached kids right from CPAP or BiPAP, right? They're a 50-week postmenstrual age baby that's still on a CPAP of 8 that every time we try to wean it, they get tachypnic and their CO2 goes up and they can't do any physical therapy and their growth chart, looks like a road instead of a nice mountain. And we don't have a lot of other options other than to support that baby better. And when they're older, it needs to be with the trach so they can get out of a hospital and go home. And so it's not most kids by any means, but I think the phenomenon of a CPAP to trach, or I was on CPAP at 36 weeks and then I got worse, is real. I don't know if that baby got worse or if we just recognized that they weren't as healthy as we hoped that they were. But I think the data represent that as being not a super common, but an existing phenomenon.
Sure. I apologize for the specific question. Just a curiosity.
No, good question. Well, then, thank you.
Thank you.